I researched Digeorge, and it's the second most common chromosomal abnormality following Down syndrome, and the prevalence is as high as 1 in 1,600 births. And I found some very good information as far as being specific to speech therapy. It can also be known as velocardiofacial syndrome, Kaler-cardiofacial syndrome, Sprinson syndrome, and catch-22. And the reason why it can be called catch-22 is because there's over 180 different medical difficulties associated with Digeorge. And the most common problems include cardiac issues, velopharyngeal dysfunction, and immunodeficiency. Their facial characteristics are typically narrow eyes, long faces, cupped ears, and a bulbous nose. And early management is usually focused on cardiac problems, but the speech pathologist is involved pretty early with feeding issues and early communication. Starting with speech and resonance, communication impairment is one of the most reported occurring features of Digeorge syndrome, ranging from articulation, resonance, voice, and hearing, to delayed language comprehension and expressive language. Speech and communication issues may be the presenting features that alert a clinician to even consider this disorder, so we're often the first to suspect Digeorge. Speech and language is typically delayed, and children may be nonverbal until they're 2 or 3 years old. Velopharyngeal dysfunction is one of the most frequent occurring anomalies, affecting 70 to 80% of individuals. So this can cause a hypernasal tone, nasal emission of air, nasal turbulence, and articulation disorders with what they call high pressure sounds or consonants. And this can be a result of a cleft or a submucous cleft palate, and they recommend early surgical management to provide better structure and function of the velopharynx for speech and language development. As high as 75% of children of this population have significant impacted intraoral pressure, which makes it difficult to produce those oral consonants. And they substitute glottal stops, pharyngeal stops, and fricatives, nasal fricatives for phonemes. Their errors are very similar to a child that just has an isolated cleft palate, but the deficit is usually much greater in a child with Digeorge. Phonological deficits can also occur with the articulation deficits, significantly diminishing their speech intelligibility. Articulation and phonological disorders make the children hard to understand, but the velopharyngeal dysfunction also plays a role. Their dysfunction of the velopharynx doesn't allow full closure due to the cleft palate. Well, due to the cleft palate, pharyngeal hypotonia, or both, making their speech hypernasal, containing nasal emission and nasal turbulence. Surgery is usually required to help fully close the velopharynx in order to correct the hypernasality and nasal emission, and they can't build up enough intraoral pressure because it escapes through the nose. And I haven't heard or seen anyone do this, but I read that you can manually plug the child's nose intermittently just to prevent air leakage, and that'll allow them to build up enough intraoral air pressure to produce those consonants correctly. And when doing this, the easiest stop consonants to begin training are usually B and P. And you can either hold their nose with your hand, or I read that you can use a nose clip, which could be effective, but I'm sure that's very much more uncomfortable. Okay. A very common sign in this population is a language delay. A study that was conducted following children, assessing them at 6, 12, 18, 24, and 30 months, showed a significant language impairment found in their expressive language. Expressive language is usually limited up until about age of 3, but there's a rapid growth occurs between 3 and 4 that usually takes place by school entry. They still will show deficits in syntax, vocabulary, concepts, word finding, and discourse. We learned about enhanced milieu teaching, the enhanced milieu teaching model in Dr. Blodge's class, and this has been used in this population to facilitate early vocab growth by enhancing their environment. There's also a phonological enhancement piece with enhanced milieu teaching for children with cleft lip and palate that provides speech recasting so they can process the difference between the adult's production and their production. Using sign language has also been encouraged in working with these young children. And the authors of one of the articles I read said that oral speech instruction should focus on targeting oral consonants and diminishing the use of glottal stops. Another subject we studied in Dr. Plotchis was focus stimulation, and that helps increase their speech accuracy and consonant inventories. The PLS-3, Peabody Picture Vocabulary Test, and the Goldman are all assessments we can use for children under the age of 3, but the Rossetti Infant Toddler Language Scale also allows for us to analyze a broad area of communication skills, including their expressive and receptive language. Delayed motor development can also lead to a delay in maturation of chewing skills and delay of moving textured foods. And parents have reported finding pocketed food hours after a meal. And thickened liquids and avoidance of texture substances were encouraged to reduce risks of aspiration. Velopharyngeal dysfunction from a structural defect, such as a cleft palate or a submucous cleft palate, can result in the pharyngeal wall and the soft palate not being able to shut off effectively and with appropriate timing. So this can create a negative oral pressure, leading to decreased sucking efficiency. So using adaptive bottles and different positionings are utilized to increase feeding efficiency. The authors of the article I read, they said that they pay particular attention to the cricoesophageal phase of the swallow, looking at material passing smoothly from the pharynx into the esophagus. Other etiologies that can affect feeding are airway compromise, vascular anomalies, slow gastric emptying, hypotonia, chronic constipation, and irritable temperament. They have a high rate of failure to thrive at about 74% of infants. Cardiac anomalies are also prevalent in children with Digeorge, appearing in about 71% of cases. The types of cardiac anomalies vary with many patients having more than one anomaly. They may cause children to become easily fatigued, negatively impacting their sucking and swallowing among infants, which in turn can limit their nutritional intake. Many children in this population with cleft palate can learn rather quickly to feed efficiently through proper positioning and special bottles to decrease the amount of nasal regurgitation. Some of the techniques they talked about were positioning the bottle with the nipple under a shelf of bone, which gives the infant a hard surface to compress the nipple against. Another technique is cutting a large crosscut in the tip of the nipple to allow milk to flow more freely and readily, since they're susceptible to fatigue. And one of the bottle types recommended is one we observed in Clarksville, which was called the Haberman.